Good afternoon, everyone. Welcome.
Good afternoon, everybody.
Hi.
I'll just give it a minute or so, just whilst people join. We've got 18 people at the minute. Great.
Oh, thank you.
So this meeting will also be recorded, just to let everyone know, because we'll upload it to our website afterwards so other people can watch it. So the recording has started now. Okay, lovely. It's 1 minute past, so I will start. So hello, everyone. My name is Chloe. I work in the communications team at the ICB, so I've been supporting with setting up this meeting, joined by various colleagues on the call today, where we'll be talking about how the NHS and how we use patient data to improve patient care. So we'll be joined by Dr. Laura French, give us a wave, Laura, who is our Director of Population Health Management, and again, various colleagues on the call who can support with any questions. So we will have a presentation by Laura first, and then we'll go into a question and answer session. So if you do have any questions, please leave them till the end of the session, and then we can have a bit of a question and answer session there. So I will share my screen, and it did work when I tested it, so fingers crossed it works this time. I think I've done the wrong one. Please let me know if this works.
Yep.
Yeah.
Lovely. Thank you very much. I'll just get the chat up. So just a couple of house rules before we start. So welcome everyone. Thank you all for joining us. Please, as always with virtual meetings, listen with an open mind and respect each other's views. You might have questions. If a question has already been raised in the chat or if someone has mentioned it, please try not to repeat it because we will try and get to it. So we do ask that everyone remain on mute whilst the presenter is talking and whilst other people are talking. Feel free, if you've got a question at the end of the session, you can unmute and ask the question. And again, we'll have a Q&A at the end. It'll be about 15 minutes. So if you do have, obviously, appreciate this topic, there might be some kind of specific and technical questions that you might have. So if you do have any more specific questions that we can't necessarily answer in full on today's session, we will pick them up separately after the meeting. We'll send a follow-up email just to answer those when we've got a bit more detail. So I think on that note, I'll hand over to Laura. Go for it, Laura. Thank you.
Lovely. Thanks, Chloe. Can I have the next slide then, please? Great. So as Chloe said, everyone, my name's Laura. I'm a doctor and I work at the ICB here in Derby and Derbyshire. My official title is Director of Population Health Management, and I'll tell you what that is as part of this presentation. But I am a public health consultant by background. So I'm trained in, rather than having individual patients, my specialty is looking after the health of populations and helping the NHS tackle health inequalities, decide what services to put where and for whom. So what we're going to talk about today very briefly is patient data. And first of all, what it is that we mean by patient data. Talk a little bit about how the health service uses that data in order to improve care. Specifically what population health management is in that context. And then a little bit in detail about what sort of tools that we can use to do this with our data and how we know that they're secure and how we can be assured that way. Next slide, please, Chloe. So what is data is always a good place to start because it feels like one of those things that's quite simple, but then when you try and define it, it becomes quite challenging. This is the Cambridge English Dictionary version, not the Oxford English Dictionary. I think only because this is the one I had to hand. But it's this idea that it's kind of information, especially facts or numbers, but not exclusively facts or numbers, which is collected to kind of help decision making. And it can actually be, so it tends to be facts, numbers, things like that in our medical records, but it can also be things like sound clips, images, video recordings, that sort of thing. And getting the data is only really the first part of the process. So the whole point of this definition is to show that getting the information is one, but actually turning this into insight involves a whole lot of process, which is what we're going to talk about today. Next slide, please, Chloe. So information, which is what we use in the health service, if you like, is when we've processed or organised or structured that data, those individual bits of kind of information or facts or numbers that mean that we can make it meaningful, we can give it context, we can make it relevant, and we can use it to make decisions. Otherwise, a sort of list of numbers without any context is not really very useful. So that's why we need to do these things in terms of processing patient information. Next slide, please, Chloe. So actually lots and lots and lots of information is collected about us now all the time, which can sound like a slightly big brotherish statement, but actually it's in many ways it's a good thing, because these bits of information go through to informing the system in the society in which we live and work. So this is just a sort of illustrative example of right the way through from birth. And you know, we have things like birth certificates, birth registrations, so we know who is born and where they're born. We do newborn screening, so we know things about your health right from when you're a baby. Through childhood, we look at things like immunisations, health visitors keep records, there's things like exams, and then obviously all the way into adulthood. The greater our kind of footprint on the world and on society, the more data is collected about us, and the more of that data is then used to design things that work for us. So things like census data and survey data, all of that things. We've also now got the sort of unprecedented landscape of a place where we voluntarily give up quite a lot of information for things like loyalty card programs with supermarkets. You know, they know our buying habits of what, you know, I don't know, brand of shampoo we like to use and how often we buy toothpaste in a way that we definitely didn't do 20 years ago. And things like 23andMe, that's just an example, but the sort of online genealogy DNA data banks as well there's a whole new area of data collection. So all the way through our lives, lots of points of information and data about us go to create information databases. And in the NHS particularly, we're also doing this. We're building up a record of someone's life in terms of what goes on in GP care, what happens in hospitals, when you go for screening tests, so things like your cervical smears or your bowel screening, any research that you might have signed up to be a part of as part of your treatments in the past. If you have certain infectious diseases, like for example, measles, scarlet fever, we also collect data on those things. So all the time we're using patient data in the NHS, but the ways in which we're using it are becoming ever more kind of innovative, and that's what I'm going to talk about today. So Chloe, next slide, thank you. So specifically patient data, what I'm going to be sort of referring to today, I'm talking about things like your GP records. So every time you go and see your GP, the things they put down, so diagnoses, tests that they run, the results, prescriptions of medications that are prescribed. I'm talking about your hospital records, so that's every time you have an admission to hospital, either planned or as an emergency, any treatments you have while you're there, any operations, and then what goes on your discharge summary when you go home. Patient data also includes social care data. So although social care is kind of sits slightly separately from healthcare in that a lot of it is commissioned via local authorities, they actually work very closely together, and a lot of the reasons that you might need social care, of course, relate to your health. So they have a lot of data in common. Demographic information is really important also in your health record. So that's things about your age, where you live, your ethnicity, what language you speak, etc. And that's a really key part of your health record as much as any health information. And then finally, we also include information that we collect on things that you tell us around whether you smoke and how much you might smoke, if you drink alcohol, what physical activity you like to do, how often, all of those things that you get asked about when you come to a healthcare setting. So all of those things constitute patient data, and probably some other things that I've forgotten to put down on this slide as well. Next slide, please. So this information is really important for you as individuals, because it means that you get the right care in the right place at the right time, and ensure that health professionals who are looking after you know everything they need to know to be able to take care of you. But for the health system, so for me, for example, working in an integrated care board, I use health data slightly differently, and it's almost always anonymized when I get it. It's always a big sort of aggregated pool of lots of different people's data. And I use it to do things like understanding what services are needed, where, and for how many people. I do it to try and recognise things like diseases early, so we can look at infectious disease reporting data to look at what the flu situation might be, for example. So we know at the moment that flu notifications are up this year now on where they were last year, so we might be looking at a slightly earlier flu peak. So we can use it for that sort of thing. And we can also use it to detect when we think that people might be missing out on care that would benefit them. So if we have a set of information from a service and we can see that there's a group of people missing from that service, for example, we would expect to see more people from a given area of Derbyshire or a particular age bracket or a particular ethnicity. That can be a sign that something about that service isn't quite working, and because they are missing from the data, we've spotted it. So there's all sorts of reasons that we use healthcare data to help design services in that way. Next slide, please. And this has become a really big feature of the NHS's 10-year plan, which was released earlier this year. One of their 3 shifts in terms of how they want to move the NHS to a more sustainable footing for future is moving from an analog to a digital health system. And some people queried this when it first came out because it makes it sound like we were an entirely analog health system to start off with, which of course we weren't. You know, it's been a long time since we've seen things like paper records in GP surgeries, for example. However, this 10-year plan gives us a real kind of push towards the importance of data in 2 ways. So having digital and online platforms for you as patients and the public to see your records and to engage with care in ways that's more convenient for you, to have access to services, for example, that might be geographically a bit distant from you. So that kind of online facing health system. But this also talks about the ways in which we use patient data and information to design services, to commission, as we call it, services that really work for the people that we're looking after and achieve the outcomes that they want. Next slide, please, Chloe. So what is population health management? My job title is Director of Population Health Management. And what that really refers to is a specific way of using data to describe populations in terms of groups of people, and we do it according to their health needs. So we might be splitting up the population according to age bracket or ethnicity or where you live or deprivation, but we might also do it by people who we know have a respiratory illness, for example, or people who we know are using a particular cardiology service. So it's a way of describing our population so that we can segment it, we can divide it up into groups, and then we can design services specifically for those groups in ways that work for them. And it also helps us shift the focus from just treating illness as it happens, because it no longer relies on us waiting for people to present to hospitals, for example, with chest pain to know that they're having a heart attack. It allows us to identify which individuals within a population or which groups are at greater risk of a particular thing, and then try and intervene at an earlier stage to prevent that happening. The newer kind of version of population health management also now recognises the importance of things like the places that we live and work and the environment to our health. So previously it used to be a very kind of numbers driven, very what we call secondary care focused. So it would be looking very much at things that happen in hospitals, so waiting list data, number of operations, number of heart attacks, number of strokes, that sort of thing. And it still does that. But now, given that we realise how much our health is affected by not just what goes on in GP surgeries and hospitals, but also where we live, where we work, our friends and our communities, PHM, population health management, now attempts to factor information on those things in as well to improve the accuracy with which we're able to describe populations and create health systems that work for them. So it's really become a broader topic than just that. And that's why it suits me as a public health consultant, because that fits more closely with what I'm used to doing, is looking at people in their kind of broad sense and understanding all of the factors that go in to determining how well or otherwise someone might be. Next slide. So this is an example of how you might use population health management methods to do this. And this is very illustrative. I'm not got real data in here, but for example, you might want to look for people in your population who are more at risk of admission over winter perhaps with respiratory, with chest problems, because that's a common reason for admission at this time of year. And we know that hospitals get very full, get very overloaded. So what we could do then is use GP data to look for people who are prescribed an asthma drug or a chronic obstructive pulmonary disease drug, like an inhaler. We can combine that with what we know about emergency admissions. So we can find people who we know tend to have more admissions over the winter. And when we can add in another layer of risk factors, so we could perhaps use local authority data on households who are in fuel poverty, because living in a cold house also increases your risk of having a hospital admission with a chest problem. And by adding those sort of 2-3 bits of information together, the people that are in the centre of that diagram, if you like, we know that they're at higher risk of having an admission. And so if we're looking to target an intervention or a treatment, there where we're really going to get benefit for that intervention. So it might be something like really prioritizing that group to make sure that they've had their flu vaccine. So, giving them a call, reminding them that it's necessary, talking it through if they've got problems or concerns. It might be that you want to prioritize doing their asthma review or their medication review a bit earlier than you would, so making sure that they've got the right combination of treatment. And it might be that you want to think about their wider circumstances. So, you might know of a fuel poverty support program locally, or you might just want to advise them to seek advice with Citizens Advice or wherever. So it's about finding the group of people for whom these interventions are really going to benefit and targeting them there, rather than kind of having to spread yourself more thinly, if you like, talking to everyone about flu vaccines. Next slide, please, Chloe. Thanks. So how do we do this? Because it sort of sounds quite simple, and it is quite simple in terms of the principles underlying it, but obviously what we're talking about is combining lots of bits of data from lots of different sources, and it's all important and sensitive and confidential data. So we need to think really carefully about how we do it. You can do a lot of this with just publicly available data that's completely anonymized. There's no way anyone can tell who anyone is from it. And these are actually surprisingly available, and you can have a look at these yourselves if you're interested. So we get a lot of our public health data from the Public Health Outcomes Framework. That's on a portal called Fingertips. So if you just Google Fingertips or PHOF, Public Health Outcomes Framework, you'll be able to access those. And that gives you loads of different like what they call indicators, so bits of information about population health, and you can look at it by ICB area. So like Derby, Derbyshire, you can look at it by local authority area, and some of it you can even split down and look at by practice or pre-CNs, a group of GP practice areas. So we can use that data a lot, and that's really helpful. Our 2 public health departments, in partnership with NHS organisations and other provider organisations, produce something called a joint strategic needs assessment, which is basically where they use lots of data, as I've been describing, to do this, produce this very thorough description of the health of their population for a given period, and it looks at what is needed and what's there and what we're doing well and what we could be doing better, and they're really good documents as well. So we do use those already, and other specific health needs assessments. So often when we're thinking about redesigning a big service like the sexual health service, we will do a specific data gathering descriptive exercise. So a lot of these are, because they're completely anonymized, published, readily available, no problems there. If we want to do something of our own with data that is gathered from our patients and is kind of less, it's not those big national bits of anonymized data, we've got some other tools that we can use, and there's a list of them here, but they're basically tools that we can use either within the ICB or our partners within primary care can use. And you might hear or see these referred to, but tools like Radar, which pulls in data and allows you to do that risk stratification. You might see, so Power BI is another program in which we can create dashboards and look at. Often, again, it's not named data, but we can use this to kind of slice up our data and look at it by different ways. But there are quite a lot of products available to do little bits of this process. But what we really needed was a platform where we were able to bring together data from lots of parts of the health system together and layer it all up and make those decisions. Next slide, please, Chloe. So Another tool that we can use is something called the Federated Data Platform. So that is a secure data environment. So that's like an online data vault that keeps data very safe, if you like. And this was commissioned by the National Health Service a few years ago because they recognised that the challenge of bringing different bits of data together from across the health system is really difficult. And so the idea is that it allows us to effectively bring together all of these bits of information we collect about people in one place where we can safely and securely use it effectively to design care systems. And the FDP itself, the platform's been around since 2023. Derby and Derbyshire are going to be one of the first sites in the country to use a new specific tool within that platform called the Population Health Management Tool. Or sometimes called the strategic commissioning tool as well. You might hear both terms used. And the idea of that is that it helps us to spot variation. So it allows us to benchmark against similar areas, and it allows us to spot variation that shouldn't be there and plan care more effectively. Sorry, I've just seen someone put in the chat that they can't hear. Can everybody else hear me okay?
Yeah.
Yeah, okay. I might just pop a message into whoever it was. Nazreen, yeah, I think it might be you. Does someone mind just popping a little message in the chat to suggest that they try logging out and logging back in again? Because I think it's I think the problem's on their end. Thanks. And then can I have the next slide when you're ready? Thank you. So the FTP PHM or strategic commissioning tool, I think I've used PHM tool throughout. It has two parts to it. So the first bit that we get first just uses those big national commissioning data sets. So that's data sets that are collected largely through what we call secondary care, so hospitals, rather than things that are happening at GP level. And we kind of already get access to these databases in different bits, but this tool will allow us to pull them all together in one place, and allow us to kind of segment them, cut them up, look at them how we want, so by age, by geography, and use them in combination with other bits of data. Just let Nazreen back in. I hope that works better for her. The second phase of the FTP tool is called the Local Analytical Hub. And this is the really key bit that I'm really looking forward to having, because it will really make a difference to the way that I'm able to look at population health and design services. So this will flow in some local data sets as well as those big nationally collected ones. And that will include local social care data and local primary care data. And that's great because primary care data holds a much greater richness of information about you. And you can imagine why, in terms of how often you go and see your GP, such a large percentage of contacts within the NHS occur within primary care, within GP surgeries, rather than, in hospitals or other specialised settings. There's so much brilliant information there. And it also means that we will lose some of what we would call a secondary care bias to our data sets at the moment. So because of where we collect the majority of the data, we tend to those are the bits that we really see. We kind of miss a lot of those things that people are perhaps presenting with more commonly, but never quite make it to hospital. I've just seen in the chat, I'm just going to respond. Guys, I feel bad that they can't hear me. Okay, next slide, please, Chloe. Thanks. Yeah, so vast majority of care that happens in the NHS happens in primary care and community health services, and it's really important to have this information when we're putting together health services. Sorry, I'm also going to turn off the chat notification because it keeps covering up my screen. Great. The local analytics hub, so therefore will eventually allow us to flow in that data, combine it with the big national data sets and everything else to get those really detailed pictures of what our population health looks like, what services we need, where we need them, who might need more, who might need less. And then we can, from my point of view as someone in an ICB, can use those really effectively when we're thinking about how we allocate resource, how we plan services. But the beauty of population health management and the FDP tool is that eventually it will allow us to generate lists of people for whom a particular preventative intervention might be of particular benefit. So although I will never see those personalised lists because I don't have responsibility for direct care for patients, we'll be able to share them with, for example, GPs or hospital doctors, so direct care providers. And so we'll be able to layer that data up, find that group of people who are in that kind of circle of different risk factors, and share that with a care provider to say, these are the patients who, will particularly benefit from this particular intervention. So it allows us to really effectively target what we're doing for the people who will derive the most benefit, the people who need it most, or the people who are at highest risk. Next slide. Thanks, Chloe. So what are the benefits for this for patients? So this being able to use the data in this way means that we can create services that better match our population's needs rather than those designed on kind of average national data, which is what we would otherwise be using. So the more specific we can be with our data, the better the information that comes out in terms of how well it relates to you guys in Derby and Derbyshire. It gives us more opportunities for proactive preventative care. So it allows us to spot people who are at, at risk of particular outcomes and put things in place to prevent that happening further down the line. The idea of it is that it also reduces health inequality because it allows us to fold in all of those bits of information about all the things that we know that affect our health that aren't just what goes on in the health system. So we can include things like data on housing, on poverty, on air quality, on all of those things. So that means that we can also find the places where people are experiencing health inequalities and help work out how we can change things to make it work better for them. And it also means that we can do that really accurate identification of risk profiles for different groups of patients, and we can kind of therefore stratify what we do and offer preventative intervention. Next slide, please. So data security, obviously everyone is worried about this or likely to ask about this because this is the most important thing when we're talking about people's data, is the responsibility that we have to keep it safe. So every organisation that provides health and care services already takes every step that is required of them to keep data secure. They will always use data where you can't be identified wherever possible. And for example, I very rarely use patient identifiable information in my work because a lot of what I do is at population level. So I don't need to know who's who. I just need to know kind of broad numbers. And we will always be using that data to benefit health and care, whether that be directly for patients or whether it be for patients as a population. We'll never use the data for marketing or insurance purposes. Obviously, if you need a specific report for something, then you can request that from your primary care or other provider appropriately. But we, as the health system, will never do that without your requesting us. And we'll always make it clear why your data is being used and how it's being used and what it's being used for and why we're doing it. So the GDPR and other information governance regulations make it clear that we can't use data unless we have a clear reason that we're doing it, and that we're not using a level of identification that we don't need. So keep it as anonymous as we can whenever we can, and that we need to have a clear idea of what we're doing and why, and the benefits that come from it. And the Federated Data Platform adheres very strictly to those NHS England secure data environment policies. And I won't go into the technical detail, partly because I'll probably fall down quite quickly when I start talking about privacy enhancing technology. But within the different elements of the FDP, the Federated Data Platform, and the process that may end up in creating a list of people, what we call pseudonymized, so individual patients but without names, to then turn them back into a patient list for a provider. There's some very sophisticated privacy enhancing technology in there that means nobody other than those who need to will ever have access to identifiable data. Next slide, please. You may have heard about national data opt-out or seen this somewhere or seen it discussed. The national data opt-out basically allows patients to opt out of their confidential information being used for anything other than what we would call direct care. So obviously your care record gets used when you go to a health setting and you need to access healthcare. That's direct care. But the things that we've been talking about in terms of using data for analysis and health service design and sort of research in terms of looking at what we do and whether it's the right thing, that's non-direct care. So you can absolutely opt out of that, your data being used for that, and all NHS organisations must comply with that. The ICB will always check all of our data uses against those rules that were on the previous slide and whether or not there's been data opt-outs. And we also monitor the usage through regular information asset reviews. So that an information asset is where we hold a particular bank of information. So we always review that we're not holding anything that we no longer need or that we need to be holding in a different format. So that's continually reviewed. We don't keep anything longer than necessary, and we don't keep more than we need about particular people or groups. Opt-outs, as I've just discussed, so they don't affect your direct care, and they would never prevent data sharing in an emergency if it was required for you or in a legal obligation. It's just about those secondary uses in terms of designing healthcare services for population benefit. And patients can change their preferences at any time. So there's some quite good information on the NHS digital website about how to do this, but you can do it through the NHS app as well. There's an option to put in there, or you can go online, and if you just Google NHS National Data Opt-out, it will take you to the relevant page and it shows you how to do it there. Or there's also some contact details if you wanted to discuss it with people. Next slide, Chloe. Oh, there we go. So we've got to the end of my slides. Apologies, that's taken me a wee while, but I wanted to try and be thorough on what it is that I like to do with data and why it's important. I'd love to invite anyone now to ask any questions. So feel free to put your hand up and ask them yourself, or if you prefer, pop them in the chat. And then otherwise, if there's sort of quite specific questions that relate to perhaps your own circumstances or very technical questions that you'd prefer to submit to us to be answered separately and afterwards, we can absolutely do that as well. So I'll just give everyone a little bit of space in case they can think of anything that they want to ask. I appreciate that was a lot of information in a short period of time, so it's completely fine if you want some time to think about it. I've just seen a question. Nazreen, lovely. How long is patient data kept before deleted? Good question. And you're checking that I've done my information governance training here. So the idea is that it is never kept longer than necessary. However, there are statutory limits on how long it can be kept for, and those do vary depending on the type of data and what it's for. So, for example, I used to work in obstetrics, and we keep birth records for a long time because people who might suffer complications of a complicated delivery can want to pursue that into adulthood. I'm not sure if there are any broad brushstrokes guidance, Jed or Leah, that might be helpful to share on that in terms of numbers of years that you can keep data.
Yeah, so we always do it in line with the NHS Records Management Code of Practice, which is a code of practice that's in place for all NHS records. Typically in these instances, it wouldn't be more than sort of 6 years, and then that should be deleted. But with this, again, typically there's a refresh of data consistently coming in. But like Laura said, it would be dependent on the type of information that we're holding and for what purposes.
Thanks, Leah. Yes, thank you. I mean, that's partly from a point of view of good information governance, and thanks, Jed, for that link. That's really helpful. That's the NHS code of practice there. So it's partly for that reason, also partly a purely practical version, which is that data and storage of data takes up a lot of space, like virtual space, if you like, and therefore it's important for keeping everything running to refresh every so often and make sure that what we're holding is up to date and it's the right thing that we need, and we've not been keeping things too long. So thank you for the question. It was a great question. Tim has asked regarding the opt-out. So does opting into research and planning beyond direct care also opt the patient in for marketing and or insurance purposes? Another great question. No, absolutely does not. So the NHS does not use or sell data for marketing or insurance purposes. We'll only share things about you without your consent, and if there is a legal basis to do so, you know, in the sense that we are concerned that you're at risk to yourself or others, or we've had a legal request from law enforcement, for example. But no, we would never do that. The opt-out is purely just if you don't want your data to be used by the NHS, but for those broader purposes. It's never going to leave the NHS or the partner organisations. Recognising you're working at an ICB level, narrowing the focus a little, do you know how my GP surgery uses patient data to improve patient care? It's another good question. And my first thought for that is, if you would like to know specifics about how your GP surgery is using your data for patient care, then the best thing to do would be to contact them, and I'm sure they would be happy to provide you with a copy of their data policy, but also information on any kind of population health management work that they might have been doing. In a broader sense, as you say, because I kind of work at integrated care board level, there is an element of population health management and risk stratification, which is a little this kind of using patient data to target your resource. There is an element of that in one of the primary care contracts. So all GP practices and PCNs to a certain extent will be doing an element of this, and actually they have done for quite a number of years. So you may have heard about QOF data, which is one of the types of data that GP practices collect, which allows them to monitor the health of their patients, and it also feeds into their contract and allows them to be paid from their national government. So a lot of them for quite a few years have been using that data to look for patients whom they need to contact, particularly, for example, for things like flu jabs or asthma checks. Or so you will find that to varying degrees, practices will be kind of using data in this way. But there's that interesting difference between primary care and what I do at an ICB, which is that primary care generally are doing it because they are looking for lists directly of their patients for whom they have direct care responsibility for things that they need to intervene and do, whereas I tend to be looking more broadly in terms of the population and whereabouts we might need to put services or allocate resource. So theirs is very focused often on what are the best things I can do for my particular patients in this surgery. But it's a really good question, because it is, whilst it's the same principle, it looks slightly different if you're doing it in primary care, and I'm sure they'd be happy to provide you that information. The data security, but I should also say in response to the last question that many GP practices and PCNs have recognised that PHM methodology is the way forward, the future, and is a great way to be designing ethical care and targeting your care best for your patients. So I've had a lot of really good conversations with people who work in primary care and in the PCNs about how I, as a PHM director in the ICB, might be able to work together with them to do that more effectively. So I think I'd love that we would see more of that going forwards. If everyone could just check their mics, because I think someone's gone off mute, that would be great. I've got a bit of an echo. Thank you. Perfect. Tim, the data security bullet says, will not use data for marketing or insurance purposes unless you request this. Is there actually a process for patients to actually request the sharing of their data for marketing or insurance purposes? Not that I want to. Okay, yeah, well done for asking for clarification. There's not a specific one, because this is not something that routinely the NHS would ever do. However, and people who work in primary care will know this, it's not infrequent if you are taking out an insurance policy, for example, or you might want to apply for a particular job that requires a particular health status, or similar, I don't know, you might be taking part in a research project for a private company. They might request from you specific data about your health. And if that were the case, then you could apply to your primary care for a sort of print of your records or a report or whatever. Or sometimes they might provide you a form to sign to say you give permission for the, but generally speaking, that's very much not kind of business as usual, if you like. It's just something that sometimes patients require requested. And I should probably, for the sake of my primary care colleagues on the call, point out that providing reports like that does not fall within the NHS contract terms and conditions for general practice. So there will usually be a charge associated with a report of that nature. It's more just that is a reason why people will occasionally request data from the NHS beyond the things we've spoken about. But thank you for the clarification. Just seen a new message appear. Oh, thank you. Thanks, Tim. Pleasure. Right. Thank you. Sorry, I'm taking a risk here and there. I'm reading something aloud before I read it out first. All come back to basic patient data being entered in an accurate, timely and appropriate manner. So you're dependent on the quality of data and how complete it is. Does that concern you? Again, very good question. And yeah, data, like everything, is entirely dependent, you're right, on the quality of what goes in. So our analysis and our software for holding it might be top notch, but if you haven't got the correct inputs, then that can be a real challenge. And you're right. And I think it's something that everybody throughout the health services has recognised as we've gone through our digital evolution together, that there have been lots of different ways of recording information with varying amounts of completeness and accuracy. There has been a lot of work on how we standardise and include information in patient records over the past, probably 10 or slightly more years. And some of it's been sort of to do with how we code things, particularly diagnoses, and the standardization of the use of something called read codes and the way that we kind of put data and information on people's records in secondary care. So a lot of that's gone through a lot of standardization. And so demographic information is the other one that's a real challenge, particularly ethnicity coding. And I think often that gets thought about as a bit of an afterthought because people don't necessarily think of it as being directly relevant to patient care, particularly if you're in an emergency situation, and I can absolutely see why. But actually, of course, we know that your ethnicity, as well as a number of factors, have really important influences on your health and well-being. So we've been doing a lot of work in the NHS and locally about how we kind of improve ways that ethnicity is coded, from things like offering more codes. So, there's sometimes you'll see very few options, and often people might feel they don't identify with any of those options and therefore be more likely to tick the prefer not to say box. It might be that there are emergency situations where people just forget to ask and then maybe guess based on what's been answered before. So there's something about the options that are offered being sufficiently descriptive that people feel that they identify with them, helping staff to feel more confident about asking those questions in a way that doesn't feel awkward. And also just something I think about making people understand why this is almost equally important as specific health-related outcomes for us when we're thinking about population health. But yes, excellent question. Very well spotted. Next question. Can you confirm patients
Sorry, I'm just going to bring Clive in on that one.
Sorry.
Might want to jump in on that. Yeah.
Oh, hi. Yeah, I'm Clive Newman. I'm the Director of Primary Care for the ICB. Just to follow up with, I agree with, it was a very good question about, data, what the quality of the data is, and Laura's absolutely right. And I suppose the other potential benefit of bringing data sources together is that you get more data points. So when you're trying to understand the health of an individual or of a population, you can combine different data points. So if there is an error in one, it will be, if you like, diluted, and you'll be able to get that rounded picture. So potentially the opportunity to bring data sources together will help ameliorate any individual errors in any specific coding. Though I think it's also fair to say, as you've said already, Laura, that providers are, well, always have done, but continue to work, don't they, to improve the quality of their data. It's an enormous thing within the NHS. It's increasingly important, and we spend a lot of time as commissioners working with providers to make sure that their quality of their data is as good as it possibly can be. But it will always be an issue.
Yeah, absolutely. I think anyone that's ever entered large numbers of things onto a spreadsheet will know that no matter how hard you try, things will slip through. But yeah, I'm absolutely right, Craig. The providers are working really tirelessly to improve this because they recognise that it's important. Brilliant, thank you. Oh, and yeah, Jed's just put some information there about our primary care data quality support and various other things. Thank you. There's a question about organ donation, which is actually an interesting one from a patient data point of view. So it's about, I think, Nazreen, the opt-out nature of organ donation in this country. So this was a change to the law a couple of years ago, that rather than people needing to specifically opt in to be an organ donor in the event of their death, the consent is sort of assumed to be there unless, for a number of reasons, you've specifically said you don't want to, or you've appointed a representative to decide on your death, or there's a few other things. So if you're under 18 at the time of your death, if you're not deemed to have mental capacity, etc., etc. So I think, I mean, there has been a reasonable amount about it in the press. I think patients do probably know. I think in reality, there's been a period of transition, and therefore clinicians absolutely understand that and probably have still very similar conversations, because families and loved ones are important. So yes, although technically the law has changed, and there's some very good information about that online, actually. The just trying to remember the NHS. Oh no, it's a UK.gov did a consultation outcome as well, which is quite interesting, but it kind of goes through some of that in detail. But it was a change, but fundamentally it will always still be discussed at that point. So there's not anything on your medical record anywhere that specifically says anything. It's a separate sort of information base, but like anything in terms of patient preference around care at point of death or otherwise, it's very important that you feel free to share these thoughts with your care providers, with your loved ones, because you can always change your mind and discuss these things. Hi, Nazreen.
Just had to put the audio on just to talk to you. Sorry.
No, thank you.
I'm just concentrating on patients that may not be aware of the fact that it's assumed that you may be a organ donor, and it's just a situation that the person or patients from ethnic minorities communities may not be aware of, because they've not signed anything, not agreed with anything, but they do need to be more wary of it. And that's why that question was coming up for me, in terms of some patients saying we're not going to donate our organs. It depends on where they're coming from and how they feel about their religion, and
Of course,
if
yeah.
it's assumed. And I'm just wondering, do patients get asked that when they go to appointments? Because if it's assumed, it's automatic in one sense, but it should be something discussed.
I think in reality, even though it's legally kind of there in law, it would always be discussed. I think probably that's slightly outside of the scope of what we're here to talk about today, because it's specifically about data usage. But I absolutely appreciate that it's an issue that's come up for you and for your community.
It's a question. It's just a question.
Yeah.
Is it still assumed that people are donors, even though they may not know about it? That's what I'm looking at. Patient information.
Okay. Yeah. In that case, I would have a little look at the resources available on the web.
Yeah.
But yes, I would probably. I think it underlines the importance of having conversations about wishes like that with your loved ones and with your care providers. But yes, I would reassure them that it is still very much a discussion. It's never going to be something that we kind of mandate or anything like that.
Yeah, I understand. Thanks. I respect your answers. Thank you. Thanks. Can you send the links, please, if you've got any?
Yeah, I'll pull them down for you.
Thank you.
Lovely. just realised it's gone almost dark here, which is ridiculous considering it's not even 3 o'clock, but I think it's related to the horrible weather. Are there any more questions from anyone? I don't think I can see any in the chat. No, lovely. Well, in that case, thank you so much all for coming, and also thank you for the brilliant questions, which were really important for raising like very important things. So thank you. Good idea about the questions being placed into a document and distributed along with the slides. I'm not sure what our comms team's plan was for distribution, but it's a good one. So thank you.
I'll pick it up, Laura. We'll share the recording.
Yeah,
anyway
I
as
think
well,
a little
so,
FAQs might be helpful. Brill. Lovely. In that case, thank you ever so much, everyone, for joining us on this horrible rainy afternoon. I appreciate it, and for all your questions. And yeah, if you think of something afterwards that you wish you'd asked and didn't think of at the time, just let us know via email. It's not a problem.
Thank you, Laura. Thank you, everyone, for joining.
Thank you.
Thanks, Laura.
See ya. Bye.
Bye.
Thank you.